Welcome everybody to the Random Anesthesia Topic podcast. In this episode, we have Dr. Natasha Bartel from King's Animal Hospital in Ontario, Dr. Ryan Bailey from Premier Veterinary Group in Chicago, and I'm Dr. Gianluca Bini, owner and founder of Safe Pet Anesthesia, a training and teleconsulting company, and I'm an assistant professor of anesthesia and analgesia at Oklahoma State University. Let's get started. So tonight we are joined by Dr. Mika Hamilton, which is an assistant professor at the University of Toronto and a staff anesthesiologist and intensivist at UHN. Thank you so much for being here with us on the Random Anesthesia Topic podcast. So I have a lot of questions for a human anesthesiologist. I once attended a course that's usually done for human anesthesiologists at the Royal College of Anesthesia, I think, in London.
Mm-hmm.
And they all looked at me super weird when I was like, I'm actually a vet.
Yeah.
Surprised they didn't quarantine you in the tropical disease unit.
Yeah.
They were about to. But I got even weirder looks when at lunch somebody asked me, like, what do you normally give to dogs for pain management and opioid wise? And my answers was methadone. It's one of my favorite, opioids.
Yeah.
And they were like, on which planet do you even live? So I assume that that's not an opioid that you guys normally use. So, of course, you guys have way more access to fancy toys than we normally do, but just for a matter of cost. But, I always wondered, right? Like, so does methadone has even a place in human pain management at all?
I would say we use it very rarely.
Okay.
Obviously, if a patient comes in already established on methadone from home, then, we do our absolute utmost to continue it. And it may have more of a role in our chronic pain patients. But from a sort of perioperative anesthesia perspective, I can't say that I've actually ever used it unless I've ordered it to make sure the patient gets the regular methadone when they go back to the ward.
So what do you normally use? Is it just fentanyl or morphine, or what do you...
Yeah. So, when I worked in the UK, it would be fentanyl and morphine, usually fentanyl for induction, and then, for acute pain postoperatively, and morphine for, more long acting. Then when I moved over to Canada, and, maybe this is just the center where I work, but we tend to use hydromorphone instead of morphine. I do not know why we use one over the other. We have both available. I think a lot of the time your practice is a little dictated by kind of where you work and what's sort of established, to be quite honest. So in my practice, we use fentanyl for induction, fentanyl for pain relief. We can use fentanyl for PCAs, but more often we would use hydromorphone for post-op pain, IV and oral. We also use a fair bit of remifentanil as well, which is super short acting.
My
so
favorite.
So definitely just a sort of perioperative medication that we would use. So yeah.
I want to point out Tasha's face because I love remifentanil, but
I don't hate remifentanil. Like, it's just a weird favorite to like. You're just annoying. Like, it's just a weird thing to be like, oh, I love drugs that disappear in 4 minutes. Like, no.
Why not?
It's so reliable.
It's amazing.
It's amazing, I guess, in the right circumstances. But like, if I had a shattered femur, I wouldn't want to be recovered on an acute like remifentanil CRI that someone stopped.
No, for sure.
Because I'm a big believer. Like, I'll kick you. A terrible patient.
To move your leg though.
Other leg. I've got 2 for now. All right. And can I ask, actually, Mika, why I know that methadone is very much used in like the human medical realm, particularly like when I've seen it used. When I've gone on human anesthesia rotations, it's often used for people who, like it was most commonly used for like heart valve replacement in patients who had like a history of chronic IV drug use. And so they'd actually been transitioned over to methadone, and the anesthesiologists were, giving, or in the first the anesthesiologist, then the perfusionist, and then back to the anesthesiologist, were giving methadone just so the patient didn't go into acute withdrawal. But is there any like thought at all about why methadone, for example? Because I mean, we like make it rain with methadone in veterinary anesthesia, even though, for example, like I was trained back in vet school mostly on morphine. Then we all went to hydromorphone, and now we've all shifted a little bit more to methadone because in our patient populations we find that methadone tends to be, like less amidogenic and it doesn't quite cause the same level of tachypnea. But on the other hand, it's not that great of a sedative. Like, why don't people use methadone, or is it convention, or is there a different pathway, or what's happening here?
I am going to say it's probably convention. I think methadone in human use is probably just more associated with like other functions rather than sort of perioperative analgesia. So
Yeah.
like say the patients who have had like an opioid dependence disorder, or the patients who have a chronic pain and they're on sort of a multimodal regime. It tends to be fairly, well, I would say in my local practice, fairly isolated to those indications. It might get brought out, for example, if you've got the patient who's post-op and they're on the ward and they're being seen by the acute pain team and you just cannot get on top of their pain. It may be something that's considered as an adjunct. But yeah, it's just really, yeah, it's just I've really not seen it used very much in humans at all in the
Yeah.
perioperative phase.
Because
But yeah,
we'll use it in primates, right? Which,
right, yeah,
Yeah, for sure.
chicken, couldn't get any closer, but yeah, we will
Basically the
use it in
same.
primates. Basically the same. We're just naked.
yeah. So what do
Hairless apes, right? But no, that's
you?
interesting because I mean, particularly like methadone, like I've used it in goats and horses and dogs and cats and rabbits and like the
Mhm.
whole spectrum of these guys. But yeah, it's very. I just usually when the same thing with Gianluca, like you say that to a human anesthesiologist, and they're like, what?
Yeah.
But like I said, it's probably these days. It used to be hydromorphone, but these days it is very methadone centric practice. So.
And
Yeah.
what are the main reasons for that in veterinary practice then? That methadone's now the analgesic of choice.
Um,
Well, I think part of it is that we see a lot of emesis with. So the way veterinary anesthesia normally in 99% of places work is that usually you administer your pre-meds IM, because oftentimes you can't have a patient stay still enough to place an IV catheter, right? So in order to place an IV catheter, we usually want to have a premedication IM that sedates your patient enough to then place an IV catheter. So our usual combination for IM pre-med is an alpha 2 agonist, usually dexmedetomidine, and then if they're going to surgery, usually a pure mu opioid like methadone. If we do give morphine or hydromorphone, our patients do tend to vomit. And so then you either give them antiemetic soon enough in the morning before you give the pre-med to try and minimize the risk of vomiting, or your patient is going to puke. So like with methadone, we don't see that as much, or actually almost never really. They never vomit. And so it's a pure mu opioid. It has a little bit of an NMDA antagonism as well, which is kind of unique amongst the opioids. And then it doesn't have the vomiting side effect. It causes a little bit less tachypnea compared to like hydro and morphine.
You don't see like that idiopathic hypothermia that cats get that you will see, for example, with like oxy, morphine, like methadone doesn't really give. We do see idiopathic hypothermia related to opioid use in cats, which tends to be self-limiting and will resolve once you stop dosing them. But you don't see that when you use methadone nearly as much as you would, for example, some of the other Pumius. So, but cats are really an entity unto themselves, and
In
And
all ways.
even if we do give it hydro IV compared to methadone, you still see a lot more, maybe not vomiting, but you see a lot more like signs of nausea, if you think that exists in dogs and cats. Like you see a lot more of the like hypersalivation. I would speculate they tend to regurge a little bit more relative to methadone.
wait,
I don't know if
when you said that nausea, whether it exists in dogs and cats,
Well,
are you?
there are people out there who are like, nausea doesn't exist because it's like the perception of the idea that you're going to vomit or something. It's like because animals don't have conscious perception. I'm not here to talk about it.
I'm
It's
going to
just
disregard all of those stupid remarks. Yeah.
yeah. There's people who say these things because like there's some really good stuff on nausea in dogs and cats and like or mostly in dogs and so we were like, well, does nausea actually occur? It's like, how do you tell? Like, we're putting these symptoms into a class. Like, we're saying the
So
dog's
we're
like
being accused of
hypothalamic.
anthropomorphizing as usual, right?
Yeah, exactly. Yeah, I'm not here like
I just wanted to make sure that you were on the side of believing, quote,
yeah,
in nausea
for
and
sure. When the dog's drooling everywhere and like keeps licking their
heaving.
lips like they're gonna fucking vomit, like yeah, that dog's nauseous. I don't know what to say. Like that's the word I'm gonna use. I guess some smarter person can tell me why it's wrong. Whatever.
Fine.
So one of my dogs ate an entire pack of nut brittle last year. He definitely looked nauseous all night.
Yeah.
Yeah,
Yeah, of course.
poor guy.
And it's a schnauzer. So 100% the pancreas was like, ooh.
Oh yeah. Luckily he was okay, but
Yeah,
he was
those
not. He was
guys
not.
are basically the bread and butter of the internal medicine service. Like,
Right. Mhm. I
Yeah.
guess the thing with us in humans is when we use these sorts of opiates. I guess we're always maybe me. I always want to prevent nausea, so I will always give it with an antiemetic. So, our favorites is ondansetron and
ours
dexamethasone.
too.
So,
We don't use steroid as an antiemetic.
That is a great point. Like the steroid use in human anesthesia is
Wild.
so vastly different. It's fascinating to me. Like the fact that like I've heard that before in that like oh yeah we use DexSP or dexamethasone as like a antiemetic drug or like there's something and I'm not gonna remember this because it's like just a passing thing I learned many moons ago. But something about like mucoceles and giving dexamethasone to like patients like postoperative mucoceles. I'm just like, whoa, if you brought that to the clinic, they would like be like, who brought the witch into the clinic?
The shaman.
Yeah, like, oh, what are we doing? Yeah.
Yeah, no, we don't bandy steroids around a lot, especially because we don't really see any difference in terms of like nausea levels with our patient populations. But because we really can't mix nonsteroidals and steroids in most veterinary patients without causing severe GI upset, if not perforation. Like it's a big drama if you have to give an NSAID with a steroid. And, steroids are reserved for very specific indications, like adrenalectomy, for example, or Addisonian, or, if a patient has, for example, is IMHA or IBD, like all that kind of stuff.
Yeah.
So anesthesiologists and vet med generally don't we don't sprinkle the steroids around, I don't think, at the same level that it seems to happen in human medicine, which is very interesting to us comparatively. So
yeah, we use it quite a lot for
yeah.
sure.
And do
Yeah.
humans get the same sort of like issues associated with like if you had a steroid on board and then you took an Advil, like is that a major consideration? Because like this would send our critical care team like off the end of the earth if we did that.
Yeah, so not really. We usually just give the one dose, in
Yeah.
surgery, and we'll usually give it near the start of the surgery, so it's got kind of time to kick in for when the patients are waking up. So we generally don't have much concern around adding in the non-steroidals.
So that's so weird because the other species that's like that is a horse, right? Like they jack up horses all the. Sometimes they double the NSAID and give a steroid, and you're just like, oh, I'm gonna pretend I didn't hear that. And horses generally seem to do okay. But if you did that to a dog or a cat, they'd either go into renal failure or perforate like within 48
Wow.
hours. So
Okay.
yeah, Now,
Good to know.
can I ask a question? I have a really important question. Okay. So, Dr. Hamilton, as a general rule in veterinary medicine, veterinary anesthesiologists do not care for veterinary surgeons. And I'm just wondering whether or not this sentiment is also true of human anesthesiology.
So,
So,
so I'm going to say that you're probably going to be like, yeah. But the center that I work in, I actually work with a really great group of surgeons. We have, pretty collegial atmosphere. And that goes to like the whole OR team actually as well, like our nursing staff and our attendants. So I'm quite lucky because obviously I have heard that maybe relationships are not so great in other places, but I'm quite happy where I am, and I think one of the big things is the familiarity. Is you're working with the same person routinely, so you know what they like, what their quirks are. They know yours. You can have a respectful discussion, respectful relationship.
we don't know any of this. What's that like?
But it's
And
really
honestly, we can
important.
edit this out, but now you can tell us how you really feel.
Yeah, uncut. Yeah, no. And it's really important actually because like the data actually shows that
Yes.
good relationship and familiarity of the surgeon anesthesiologist dyad actually improves outcomes
Patient
and
outcome, yeah.
patient safety.
There's a big movement right now in vet med where we're picking up on this OR cordiality as being related to not just like, emotional health for the team and like professional well-being, but also we're now looking at our own patient outcomes based on that.
Yeah.
And next year we have a symposium that's actually looking at mitigating risk. And one of our topics is discussing, the surgeon anesthesiologist dynamic and how it impacts the team and the patient. So
Yeah, for sure. I remember when I was in the UK, I think it was when I was in the UK, there was actually there was a campaign in healthcare and it was called Cut It Out. And it was all about sort of the atmosphere in the operating room and sort of being collegial and civil and how it, actually improves things for everybody, like well-being in your healthcare workers and reducing attrition and, improved outcomes for your patients. So,
Yeah.
I mean, I want to be clear that we're not the source of the issue. It's
Yeah.
definitely the surgeon.
We're not
No,
the
but,
problem.
Yeah.
no,
Mhm.
but I think
Idiosyncrasies here at all. Not in this team, not for any of us. No idiosyncrasies at all. We're easy going, go with the flow, palm
Yeah.
tree in the hurricane.
well, part of the issue, I think that the difference between veterinary medicine and human medicine is that, and I don't know if you are surprised to hear this, but most 99% of pets do not go under anesthesia with an anesthesiologist. Like, in the US, there is active at the moment, there is about 240, 250 board certified anesthesiologists, period. And so, like, and most of us are, in either academic institutions or very highly specialized referral centers, right? So, you know, big universities have 12 of us, 9 of us, and so, like, I'm not saying they're hoarding us, but they kind of are. And so, like, a lot of surgeons are not used to have one of us around, right? They're not trained with one of us around, and so, like, which is interesting, right? Like, I would never want to go under anesthesia without an anesthesiologist. I think the issue is that a lot of owners don't even know that that's the case. Like, we have friends that I was at dinner with friends and they were like, oh yeah, we took our cat in for a spay, and the anesthesiologist, I was like, there is no anesthesiologist. Two of us in the whole state of Oklahoma, and one it's me, and the other one is definitely not at that clinic. So she was like, what do you mean? I was like, yeah, your cat did not go under with an anesthesiologist. I'm so
Mhm.
sorry. But and I think that that's part of the issue there, right? Like, we don't have There isn't enough of us. A lot of pets don't have access to one of us, and surgeons don't have access to one of us either. And so then when one of us comes in, um, a lot of the times it actually creates issues, right? Like in big referral centers, when they try to hire an anesthesiologist and start an anesthesia service, a lot of anesthesiologists faced problems because the surgeons get paid they get paid, a percentage off of what they make from the surgery, which includes anesthesia. Now, once they bring in an anesthesiologist, that percentage decreases because the anesthesia part goes to the anesthesiologist, right? Or it should at least. And so a lot of surgeons have that issue there with where their money actually decreases and they're not happy with it. And so
Or
some
everything's more expensive for the client. Like there's charges to factor in now the increased level of care that's being provided. So the attending doesn't see a reduced charge. They subsidize the anesthesia cost by like adding in, small fees to every case to add in the additional care that's being provided is another model. But yeah, for sure.
some corporations they
Some
don't
of them
even
are
want to
just
hire.
jerks. So yeah, it's a lot of work to break a surgeon in. I find I try to if they've never worked with an anesthesiologist before, it's a very big uphill battle.
Yeah. They're
Now,
also used to a whole level of like care that like they're having to do two sides of the coin, right? Like just not to like take the surgeon's side, Bartel, calm down, but like when they're training, they're having to learn how to manage anesthesia while also slicing and dicing in there, whatever they do, whatever it is that they do with the blade, I don't know. But, they're having to also then manage when the tech says, "Oh, this parameter is off," and they're like, they have to decide, do I focus on the surgery? Do I focus on the patient? How do I divide that attention? So there is a level of control that they're being asked to give up. And I think that I can understand as someone who has some control issues, how that could be incredibly challenging.
And as a
Just
human
to play devil's advocate a little
anesthesiologist, that's given me palpitations to think about someone having to decide between, do I focus on the surgical procedure or do I focus on the
Well, I
airway, the
think
oh yeah, no, there's
hemodynamics,
a
the
lot of wild
oxygenation?
stuff that goes on in our profession, and like I mean, sometimes we've got patients on the table, for example, that might be like racehorses can be worth millions and millions of dollars. A breeding cow that, like really produces great calves for either meat or milk can be worth hundreds and hundreds of thousands, millions of dollars. Even fancy Japanese koi goldfish, like a breeding male, can be worth like $50,000, right? And, these patients go to the table and they don't have an anesthesiologist, right? And they have, and I think that's always crazy. Like when you have like a $20 million racehorse go to the table with a fractured leg, and I mean, standing up a horse is a big drama-rama in terms of anesthesia risk. And then they don't have an anesthesiologist on board. They have like the first year out of vet school intern trying to stand these horses up. Because Bailey's like pulling his hair out in clumps. But yes, no, it should give you heart palpitations, and it gives
Yeah.
us heart palpitations. But
yeah.
there's a lot of people who don't, it doesn't seem to bother. And that includes the people who own these very expensive
But they
animals,
don't
which
know.
if it
I
were
think a
my
lot of people don't
racehorse,
know.
I would be like, I want 6 anesthesiologists standing this horse up. So
I don't think they know. I
This
don't
is
think
this.
they know.
I'm gonna ask the stupidest question today, Mika, and I totally apologize, but you're like 1-to-1
Yeah.
with like a patient. Like you are like if I'm coming in to like have a rhinoplasty, that's whatever. You're gonna be the person to like anesthetize me,
Yeah.
monitor me,
Yeah.
and subsequently wake me up.
Absolutely.
Okay, and then
Yeah.
I'm gonna jump into something that maybe you will want to cut if whatever. But like,
maybe you should use a beta blocker.
what is the role then of the CRNA?
Oh, so CRNA, I think, is more of a US style model.
Okay.
We
Okay.
don't
I also
really,
wondered that too, because I was like, I
yeah.
don't know if that's a role that you have up in Canada. Like that may just be an American. Because I do know there's some tension
It's an
there.
ongoing discussion, I believe. We do have anesthesia assistants who are able to, undertake sedation for patients, say, for example, cataract surgery or I don't know, upper limb surgery that's been done under regional block, and the patient just needs some sedation in the operating room. So the anesthesia assistants can monitor those patients, but there will always be an anesthesiologist who's supervising them.
And
If
they'd
the
be like 1 to 4, 1 to 5, maybe.
is, I
Or
think it's around
I'm sure there's some number ratio that you're allowed to do in.
it's 1 to 2
Okay, so yeah.
in my institution. And for any induction of general anesthesia and extubation, an anesthesiologist has to be there.
I'm
I mean,
laughing.
We're sniggering, Mika, because sometimes we have done like, if especially when we've been at university hospitals, like you could have 29 things under,
yeah, for sure.
and
There is
and you're
one of
by
them.
yourself. And you have, like, there's usually a nurse or a student on every case, but you're literally like, you have to know, 20 to 30 cases in your head, and you just circle all the way around all the time. And if something goes potty in one place, then it may fall apart in another. And I mean, I remember as a resident one night, I had a splenectomy bleeding out, a ventral cervical disc decompression case where they hit the artery and it was bleeding out. And at the same time, I was supposed to drop a horse for a colic surgery by myself. So that does not happen in human medicine. Nice. Knew I should have been a doctor.
I think the thing that blew my mind is the sedated cataract surgery. Like cataract surgery in a dog or a cat.
Mm-hmm.
Can't think I've done one in a horse. Is like full anesthesia with paralytics, which for us is a big deal. Like, I mean, we can do paralytics. We're good at it, I think. But like paralysis.
I paralyzed a sun bear.
That's cool.
Yeah, for us, it's strong
Good
local
on
anesthetic and then really just like conscious sedation. So, yeah. Obviously, if you have a patient that can't lie still or maybe is claustrophobic or, is not able.
Because you can tell most people, like,
Yeah.
what to do, whereas we, like lemurs, for example, don't tend to sit still when you tell them to do that for x-ray. So everything, most of our stuff goes under either very heavy sedation or general because it's just these guinea pigs are just not as cooperative as you'd like them to be. So now I have another question too. So Mika, what is your favorite type of anesthesia? Like, for example, like, are you subspecialized in neonatal or cardiothoracic, or what is your preferred genre to anesthesia?
So I'm a little bit different in that I actually spend half my time on the ICU. So then the other half of my clinical practice is in anesthesia, and I do a little bit of everything at the place where I work. So a bit of neuro, a bit of spine, general surgery, ortho, neuroradiology.
If you had to pick one.
Yeah. Okay. So I was actually thinking about this today. I've actually got a couple. I was thinking about like what's my kind of favorite thing to do. Actually, one of my favorite cases to anesthetize for is bariatric surgery.
Ooh, cool.
Yeah, so, and one of the reasons is that the patients are usually, they're so happy. Like they're so excited. They've been waiting a long time for their surgery. They've gone through the whole process, sticking to the diet, losing a certain amount of weight, going through the whole bariatric pre-assessment. And, obviously some of them are nervous when they turn up, which is completely understandable. But so many of them are like, okay, time to go. So, and they're really like, they walk into the OR and they're like, yes, and it makes a huge impact to their lives. So I really like doing those. And then my other kind of actually favorite case to do is, which is what I was doing today, is anesthetizing for neuroradiology cases. So we will do things like embolizations of like cerebral aneurysms or AVMs. And it's up in the neuroradiology suite, so it's not actually in the main operating room. And with anesthetizing these patients, obviously there's a bit of stuff to do at the start, like intubation, lines, art line, infusions, making sure you maintain very, very stable blood pressure with the aneurysms. But once you're settled and the radiologists are doing their thing, you can sit in a dark room quietly. There's no drama. There's no clanging of instruments. Sometimes there's great music on. Like today, the radiology team had lo-fi beats on, which was super relaxing. and it could be a 2-hour procedure, it could be a 4-hour procedure. You just never know. And you just sit and make sure everything's as still and stable as possible.
Sounds like my ideal case, which is why my favorite animal to anesthetize is like an adult cow, like adult like ruminant is because
I think I did not know this about you, but anyway, continue.
you don't have to do nothing. You don't have to do nothing. They breathe great. They keep stable blood pressures. Heart rate stays fine.
Oh, it's
Like
mad hard to kill a cow, right? Like there's certain animals that just drop dead. Like if you look at them, cows are robust.
that's a different situation. But under anesthesia, they are just a flat line all the way across, and you don't have to do a single. You don't have to lift a finger. You just get to make your dots, and you're just like relaxing. It's
You
great. It's
love
awesome.
that. You love going into that weird anesthesia zen zone and like the quiet hour, and you just sit and like overanalyze your ECG. I know you love that.
Oh my god, the quiet OR is like.
No, no,
Oh
no. I like the like, my hands pumping the heart, like,
my
actually pumping the heart and like we're pouring in like auto transfusions and xenotransfusions and like there's shit everywhere. Like I like the high adrenaline, high stakes stuff. But yeah, Ryan, yeah, you like to go into your zen zone.
I like that
Yep.
intermittently because I have enough of that on the ICU. So so when I'm in my anesthesia, I would prefer that not to happen. But obviously, even in the most stable case, that's
Oh
just the
yeah.
nature of anesthesia. Is all of a sudden, everyone's life is flashing before your eyes, and
Oh yeah.
that's why we're
I
trained
mean,
to
it
do what
is nice
we do.
sometimes just
So
to have a
yeah.
nice case where you kind of go in the OR and you and the surgeon, like they're in their zone, you're in their zone, you're kind of working together, but non-verbally. And like you can just tune out and it's quiet and nobody asks you any questions and that can be enjoyable. Conversely, what's your least favorite type of anesthesia?
So I wouldn't say least favorite, but I think the type that stressed me out the most, and which I don't really do anymore, was obstetric anesthesia,
Hmm.
the emergency cesarean sections. Lots of panic, lots of stress. Patients being rushed into the operating room, and you're trying to talk to them and take a history and tell them what you're going to do as you're walking down the corridor. You're not doing things fast enough. So, and this was mostly when I was a trainee. So again, there's that added level of stress. So it can be a bit of a chaotic environment. Some of my, anesthesia friends and colleagues love that.
Love it.
And they are obstetric anesthetists, and that's why they are obstetric anesthetists. But yeah, that would probably be the type that would stress me out the most, I would say. Yeah.
That is one thing we don't have to deal with. Like our patients are stressed for a variety of reasons, but we don't entirely have to deal with like taking a history in a person who is worried they're going to die or their baby's going to die. Like I can't
It's multiple layers of stress.
yeah, I can't imagine what
And for people that like
that's
things to be controlled, it can sometimes be not the most controlled environment.
yeah.
Lots of people.
I see some guitars. Do you play guitar?
So I do not play guitar. Those are my partner's guitars. He was in a band before he went into medicine. So he
Oh
has some
wow.
guitars and
Is
various.
he also an anesthesiologist?
No, he is. So he trained in emergency medicine, and
Okay.
now he is specializes in trauma, so major traumas. But he also does critical care as well. So
Yeah, most
sometimes we're
vets you
yeah.
find it's like magnets. We repel each other.
Mhm.
So yeah, I wouldn't date a vet for $1 billion, but but
We don't
anyway.
discuss medicine that much, actually. I have to say. Usually, we'll come home. It's a 5 minute debrief, and then all right, Netflix time, or yeah. Try not
That's
to
a very healthy way of doing it.
yeah, try not to talk shop too much. So
That's
yeah.
fair.
So I don't play
So
the guitar. I'm learning to play the violin
Oh,
after 30 something years of not playing the violin. I decided life can't be all about medicine, so I wanted to pick up that skill again. So
fair.
yeah.
Do you guys play an instrument like Ryan and Tasha?
I have
I
no
have grade 10
musical
flute
ability.
under my belt.
You have what?
Grade 10 flute under my belt. I also went to school on music scholarship.
Well,
And the only reason I didn't do a music degree is because my dad was like, I didn't pay all this money for you to serve tables. So I was like, oh, okay, dad.
Hey,
So yeah, he was not keen on me doing a music degree, so I didn't do my music degree. I did biology, and here we are.
I
Yeah,
have no. I played an instrument as a kid, but
like a
never.
recorder.
No, I like did clarinet and then bass guitar, but I just never. I don't have a musical bone in my body. Like I can't pick up a difference in a note. Like I love listening to music, but I like couldn't tell you the difference between a B and a C or like a C flat or whatever the hell all the notes are called. Yeah, I was. It's not my. I have learned. I've taught myself to cook pretty well though, so I think that's a pretty solid skill that I've got. I can really knock it out of the park.
Yeah, you can. Both of you actually are excellent cooks. Now, Mika, I was just wondering, because we've asked you a lot of questions, and I usually find that human anesthesiologists have lots of questions for us about some of the weird and wonderful things we do.
Yeah. So I have a WhatsApp group of my colleagues, and I just sent a text saying if you could ask, veterinary anesthesiologist a question, what would you ask? And it was like bing, 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 bing.
I knew
So
that. Yeah, that's why I was like, we should let Mika have a chance to, because I was like, I bet you there's a lot. Yeah.
there's a lot. So I'm
This
not
is
going to ask
She's
you
got her
all.
glasses on.
I know.
time to shine, everyone. Watch out.
Okay, be
So
a professional, Tasha.
some of the questions they had were, how do you monitor the depth of anesthesia in your patients?
Oh
And
gosh.
is MAC a thing in vet anesthesia?
Yeah.
Hell yeah.
Yes, okay.
So it's totally species based. So
Right.
both of those things, right? So MAC obviously varies with species. And the other thing is that monitoring depth of anesthesia varies very much between species, even within the own subclasses, right? So within mammals, fish, amphibians, reptiles, and avian, right? Like, for example, you will find that in horses, like they could be very unpredictable in terms of how sympathetic tone relates to depth of anesthesia. But once they start to have things like palpebral and nystagmus, like you better be bolusing ketamine, otherwise that horse is going to walk off the table. On the other
Mhm.
hand, for example, like camelids, they only blink one of their two eyelids. So you have to look at the difference between like the dorsal and the ventral eyelid and determine. Fish and snakes, for example, it's a righting reflex. So once they go on their back and they don't try to flip themselves, they're at an appropriate depth, if not too deep. So yeah, I mean, we still do the normal things. So we look at, heart rate, blood pressure, ventilation, all that kind of stuff. But for example, when we're looking at the cranial nerves or the physical reflexes, because, it can be very, very challenging if you have a horse on the table who's actually having ocular procedure and you can't actually monitor the eye. Because like I said, a horse will go from 0 to hero. Like it will literally, like heart rate will go like this, and all of a sudden the horse will kick its leg. So it's totally species dependent. And that's a big challenge, is to, if you are doing a broad spectrum of species, you have to memorize all that. So
Yeah.
yeah, MAC is definitely a thing. We do use different inhalants. Like I don't know if you guys have used halothane. I'm the oldest here, but
Nope.
halothane, iso, Sevo, and even desflurane. It just depends on also where you practice too, like you said earlier. So it can be country dependent. It can also be conventional based on whatever institution you're in. Brian Bailey and I did some pretty interesting horse anesthetic protocols at UC Davis involving desflurane and propofol in a sling. But like, don't ask Gianluca. But anyway, so it's species dependent, and you have to end up essentially memorize it. And then, the smaller the things get, I find I prefer doing like megafauna or macrofauna to like teeny itty bitty things, because in that case, like, I don't know what's going on. Like, all of our equipment is human based. Very little of it's been sized or calibrated for small species. And, for example, you think about a rabbit whose resting heart rate can be 260. And the rule is if you can actually count the heart rate out, it's bradycardic. And rabbits, of course, they metabolize atropine in their plasma, so they don't respond to atropines. You have to use glycopyrrolate and da 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 da. And so yeah, every little species has its own nuance. Yep, and there's over 3,000 tracheal variations within the animal kingdom as well. So that's super exciting on who bifurcates high, who bifurcates low, who has a diaphragm, who doesn't, who has a high right bronchial stem, who has a low right bronchial stem, who only has one right lung, snakes. So yeah, it's a lot. It's a lot. There's a lot of crying over board exams.
I love how you went through all the species possible. You omitted cats and dogs.
Oh, that's
True.
boring. That's boring.
You
I mean,
didn't mention how at acceptable planes of anesthesia, goats' eyes turn into bricks.
yeah,
Like, come on. Like, that's a classic. Like, oh, it's a goat. Well, you're going to look for when his pupil changes to the diameter of a brick.
yeah. There you go. So we do have MAC. We do practice MAC sparing techniques. I mean, we do a lot of local regional. I mean,
Okay.
all of us do ultrasound guided local. And I mean, I've done femoral sciatic on a beaver, like
Of course you have.
ultrasound guided. Yeah, yeah, I know. So we do it. So we do practice MAC sparing techniques. And like I said, yeah, our depth of anesthesia changes with the species.
So that
We
actually
also
led
have a lot of,
my other questions, which was from one of my regional colleagues, was asking, what is the role of regional anesthesia in your practice, and like, what are some of your favorite blocks to do?
not what it should be is the answer. Like, we are way behind, and it's super institution specific. Like, where I trained, it was just starting to become a thing, even though where Tasha trained, it was like their whole thing. And there are still places out there where they're just not the trainees are not getting the exposure to local regional, so they're coming out with like skills that are perpetuating a whole. It's a bit of a problem, but we do it. We are probably like, I don't know, 10 years behind. I think Diego's catching up a little bit, but like,
Diego's catching up. But I mean, when I went to Davis, I actually taught your faculty how to do the blocks
yeah,
because I came from
yeah,
Cornell, right? Where everyone did the ultrasound guided. But what are my favorite blocks? I like ultrasound guided interscalene for forelimb amputation. That one's really technically challenging and something that's quadruped, right? Like quadruped as opposed to an upright biped. And I really like, for hip replacements or femoral head ostectomies or pelvic fractures, I tend to do parasacral sciatic and a psoas compartment block in lieu of an epidural so that I still have unilateral function so they can ambulate postoperatively. Because getting our pets out and up and going to toilet outside, which is also very different from human medicine, is a really big part of getting them home sooner rather than later to limit, postoperative and nosocomial infection. So, yeah, those are my favorite blocks. Beanie?
I think like ESP blocks are probably my erector spinae blocks. I love those.
You're doing that mostly for like hemilaminectomies and
Laminectomies, yeah, yeah. But yeah, we're so behind. Like for example, like epidurals, they were a thing in the past, but now like it's phasing out a lot in vet med. Um, I don't know, like we're so behind humans. We're so behind. A lot of it is that we can do sedation and a local, right? You still need to do GA and a local because you can tell the dog, hey, stay still. I'm gonna do a femoral sciatic
yeah.
for your knee surgery, right? Like we can do that. So you know, unfortunately, we're really behind.
But then the big advantage is the dog is now three-legged. They can walk on three legs pretty well, and we can send home the 70 kilo cane corso to, the 60-year-old grandma who can't pick up her dog. Like that dog can at least walk out and get into the car himself and get out of the car himself, where the epidural, that dog's immobilized and probably requires extra day of hospitalization and all that. So
And you have to pick your species too, right? Like you gotta be a little bit careful. For example, that I tend not to block limbs out really heavily, for example, especially forelimbs and horses, because they actually get up by going onto their forelimbs first. And if they can't feel their leg, they tend to panic because they're flight animals. So like, it's very interesting. Like if a Labrador can't feel its leg, it doesn't care because it's still going to eat dinner. Whereas a horse will thrash itself to death and probably break more limbs. So that's also a bit species dependent. But I would say that I probably have a local regional block on board with nearly 100% of my cases.
Mm-hmm. And is it all ultrasound guided?
It is for me.
Yeah. Okay.
yeah, for most of us newer anesthesiologists, it's all ultrasound guided. Before was all peripheral nerve stimulator.
Yeah. It's same in human anesthesia. I trained with peripheral nerve stimulators, and then ultrasound guidance was just coming in as I was finishing off my training, and now it's how everyone's learning. So
Yeah.
yeah.
I think we're on this similar timeline trajectory for that anyway. But yeah, because I can do all my blocks with both the nerve stimulator. Because sometimes, if we locum in, like I might locum in a different practice, or I might go teach, and they might not have ultrasound access. So I
Yeah.
always feel that I need to be proficient in both techniques.
Mm-hmm.
There are still some wackadoos out there who are doing them all blind, which I do not condone.
Mm-hmm.
But I do know what goes on.
And on the subject of sort of, using more, I don't know, technologically advanced equipment, do you use like video laryngoscopes for intubations in some of your animals, or is it all direct laryngoscopy?
So
Not frequently.
Yeah.
yeah, we have it. Like we're not the ones with the camera on the blade. We have like Ambu makes these little scopes that you can put into your endotracheal tube, and like we use it as a stylet. So it's
Right.
not technically a video laryngoscope, although
Mhm.
they try to sell it as such.
Yeah.
But
You should,
sometimes
you should appreciate though, Mika. Sorry to interrupt, Beanie, but like dogs, and for dogs particularly, like dogs are dead easy to intubate. It's not quite as challenging as human beings. Like you could literally, like, if there was a Labrador over there with its jaw open, like I could like arrow the endotracheal tube in, right? Like, but then there are other species, for example, like pigs, which are a nightmare, or rabbits or camelids. They can't open their jaws. They have these humpy tongues that get in the way. They have terrible dentition with their little rabbity teeth. Like they're prone to laryngospasm. Their larynx is like down around the corner. So there's also species. So it depends on which case you're doing. But for the most
The
part,
horses you intubate blind.
we don't have those cool blades where
Yes.
it's embedded and that
And
you guys actually dispose of or what have you. Like we don't do that as much. No.
yeah.
What did you say, Bailey?
horses just do it blind. Just
Horses
like
are done blind, and cows are actually done by palpation, right? Like you actually put a gag in a cow's mouth, crank it open, and then one hand goes in and actually opens the arytenoids, and then you use the tube and you actually feed it in while your hand is actually on the larynx, and that way you make sure that placement is appropriate. So we intubate very differently. Like I
giraffes are
said,
the same.
giraffes are the same. Elephants are blind.
Yeah. I
Yeah.
will say though, I was at the university and their exotic service intubates rabbits with a scope.
Yeah.
30 seconds.
I used to do
Like,
it with the scope at Cornell when it was
well, like
available.
with the
Because
video
rabbits
scope.
make me want to. Yeah, I would do as a video scope to do
Yeah.
rabbits, and even
Oh
then
my
it was.
god, it was like 30 seconds. I was like, why don't we just get these everywhere? This is
I don't know.
insane.
I tend to use like my little rabbit adapted LMA for them because, yeah, I find supraglottic is easier for rabbits, so I tend to do that.
Yeah, that's
I
fair.
was actually going to ask, do you use laryngeal masks much in vet anesthesia? So
Not much, but they're around.
Rabbits.
they're around. Okay.
Yeah.
Mostly like cats. I think the ones that we have that are most commonly used is rabbits, and there is some for cats, but I don't think that anybody actually use them. It's very rare. But for rabbits, we do because they're very hard to intubate.
Oh,
Yeah.
okay.
Yeah, they'll make you want to lie down and drink for a day. Like it is just. I mean, I've seen rabbit intubations take like 4 hours before.
And
Like it's just.
why
Or
is
the
it?
rabbit is intermittently like profoundly cyanotic. Like turns blue like
They not into surviving. They're not a robust species. Like no.
yeah. Rabbits at MAC anesthesia are hypotensive for sure. MAP of 40 easily. Easily.
Yeah. I
Is it just?
usually weasel my way out of
Yeah.
rabbits when I can.
Me too. And I did my research in rabbits.
I know.
What is it anatomically that makes it so difficult to intubate a rabbit?
Well, this is a good exam question. This is a classic exam essay question, but yeah. Well, you can't open their jaw very wide. They
Okay.
have that like rodent-esque dentition, right? So they've got those super pronounced incisors that overlap. They have these terrible dental arcades. They have a lingus torsus, which is basically a hump at the back. And if you occlude
Yep.
those caudolingual vessels, like they just become cyanotic, they swell and they obstruct. You can't visualize it because it's so like it's very caudal and distal. They're prone to laryngospasm, and they're herbivores, which means they like to have cheeks full of crapola, and they don't like ruminate or regurgitate, but yeah, their throat is usually goopy, and they just usually when a rabbit comes to you for something that's anesthetic related, it's usually like a late stage illness type thing in most cases, in which case they're already on like the cusp of like totally like being non-compromised situation, and they just die, and you're like, oh god. Yeah.
Hmm.
Yeah.
None of that
So
is fun.
I,
No, we should send you a picture sometime. The other one that's a thrill
Yeah.
is a guinea pig. We actually use otoscopes to intubate guinea pigs. So
Oh, okay, okay.
yeah.
so
Really
now,
easy though with reptiles, right? Like snake, like the tracheal opening is like really forward and under their tongue, and they don't have a glottis, so you actually just pass a cold tube right through, and it just seeds right there. So
so I have a question for you now that I'm sorry to interrupt your streak of questions, Riel, but we
There's
are
so
fast.
many.
But so Ryan mentioned blood pressure, right? So what's your target for MAP?
hmm.
Like I'm assuming that I mean, of course, like we, at least in VetMed, we do use MAP as a surrogate for perfusion. We do make the assumption that if we're above a certain target, perfusion is good. We do not, at least in VetMed, have a good device that tells us, whether perfusion is good or not. I know that there is some devices that are coming out on the market, probably more in humans, that they're looking at perfusion, I guess. Do you do you have a target for MAP to stay above of, and what that is?
So it can be a little obviously patient dependent and procedure dependent, but I would say if we were going to take a number, 65 millimeters of mercury is usually what we aim for MAP.
Okay.
Give or take. Depends on the patient. If it's a young, healthy patient who's got, no cardiac issues or cerebral vascular disease, they can probably tolerate a lower MAP for a period of time. If you've got the patient that's chronic hypertensive and has cerebral vascular disease and they're a stroke risk, you probably want to run them with a higher MAP. So figure out what's normal for them. Some of our procedures, for example, some of our spinal cord surgeries, there's various, or I should say, variable evidence on this, but in those types of surgeries where we're doing, for example, say decompression and fusion in the spine, and the surgeons are operating around the spinal cord, there may be some evidence for pushing a much higher MAP target. And in those cases, we would aim for about 85, 80 to 85. So we would
Okay.
supplement that with, usually with vasoconstrictors, saying that the evidence is a little variable on that number, and it's very hard to get the exact number, but you need a number to work with for a
Right.
start, and then you just kind of vary it based on your patient. What are the comorbidities? What's their normal blood pressure? What procedure are they having done? What position are they in? Because some of our surgeries are done in a sitting position,
Mhm.
so the blood pressure here is not necessarily the
Right.
pressure that you're getting up here. So we may want to push it higher. Sometimes that increases bleeding and makes the surgery a little bit harder, particularly if it's, like a shoulder arthroscopy or something like that. So then you may have a little bit of, I wouldn't say conflict, but you'd have to balance it out. So the magic number I would say would be around 65 for sure.
Do you
Interesting.
put an arterial line in most of your patients, or?
No, I put arterial lines in for patients where I want to keep like a much closer eye on the blood pressure. So, for example, those big spine cases, neurosurgical procedures where we want to know what the MAP is so we can, try and figure out where, if we've got high ICP, we want to make sure we've got good
Right.
cerebral perfusion pressure. So we need the MAP to, do our maths and make sure we're perfusing the brain during neurosurgical procedures. In procedures, for example, like my neuroradiology patient who's got an aneurysm, and we don't want it to rupture on induction of anesthesia.
Right.
We want a nice stable blood pressure during induction of anesthesia. We'd put arterial lines in for those. I would say the big cardiac and thoracic cases, art line for sure. And then if you've got the patient who perhaps, their surgical procedure is not that extensive, but they have significant comorbidities where, you want to keep a good eye on their oxygenation, their CO2 levels, their mean arterial pressure, or and or you want to be taking frequent blood work to keep an eye on electrolytes,
Right.
acid base, even, like hemoglobin, again, particular, well, guess during a lot of our major cases, you want to keep an eye on the hemoglobin. But then in some specific cases, there's, hemoglobin targets, for example, again, in like big spinal cases. So I think the short answer is no.
Yeah.
Where I practice, I wouldn't put arterial lines in most of my patients. But if I was a cardiac anesthesiologist, I probably would have art lines in all of my patients. So yeah,
Fair.
again,
Fair.
center specific, specialty specific, procedure specific, but then also patient dependent as well. So
And what's, generally speaking, like, what's your first line for if you're going to use a sympathomimetic for blood pressure intervention? Like, what do you reach for as like your bog standard one?
when I was in the UK, it was metaraminol, which is a good
Oh, okay.
vasoconstrictor, but we don't have that here. So phenylephrine is
Yep.
what we tend to use as our first choice,
Okay.
vasoconstrictor in the OR. If there is bradycardia or a risk of bradycardia, like say the heart rate is low normal and you don't want it to drop any further when you give a vasoconstrictor, then we would use ephedrine with
Yep.
alpha activity. So those are definitely our two main ones that we would use, and they're the ones that we would generally have drawn up for most cases, just in case.
Okay.
If we are doing, say, for example, again, I keep going back to this case, is what I see quite frequently, but the big spinal case, we want to maintain that higher map than usual, map of 85 to 90. Sometimes the surgeons actually request a specific map. Then you might get to the point where we're running a phenylephrine infusion and we're running it at 0.3, 0.4, and it's just after that point, it's just not working anymore.
Mhm.
So actually norepinephrine in these patients is much more effective.
Okay.
And it doesn't necessarily have to be run through a central line. It can be run through a peripheral IV as long as, it's a reasonable size IV, it's flushing, and you can check
Right.
it regularly to make sure it's not tissued. So
Yeah, for sure.
yeah. So
Interesting.
yeah. But
I think
definitely
we reach.
are the main ones. So
I think we reach for Norebi way earlier than you do.
Okay, so I've always said this, and can I want to ask and see if this is true. I've always said that we in veterinary anesthesia tend to reach for like inotropes and less likely for vasopressors because we don't have the same coronary arterial disease where the human patients are at higher risk for having some degree of coronary arterial disease. So vasoconstrictors are generally preferred because of like the risk of tachycardias and positive inotropies together. But I don't know if that's like, yeah, like, is that an accurate statement or is that even close? Or is it just like, nah, whatever. We don't worry as much about it unless they have existing evidence that they have coronary arterial disease.
yeah, I wouldn't say we worry too much about that. I would say that our adult patients are less likely to get bradycardic. I'm going to take a guess that maybe in vet anesthesia, do you see bradycardias fairly regularly? Yeah.
Yeah,
So,
especially because we pre-med with a bunch of Dexmed.
okay. Yeah. So bradycardia is definitely more an issue in pediatric anesthesia for sure. Not so much in our adult population. Obviously, it can happen, and then there's certain procedures that actually bradycardia is a big risk. Like if you're doing laparoscopic surgery with the pneumoperitoneum, then bradycardia is going to be a risk. We also, it sounds like maybe we don't use dexmedetomidine as much as you do. I use it a lot on the ICU actually for sedation, but perioperatively we don't. And again, I don't want to say this is how everybody does it because again, it's all very center specific and specialty specific, but we don't use it a ton where I work. But what we do use it for actually is in neurosurgery and particularly for awake craniotomies. It's a really nice sedative agent, quick on, quick off. Apart from the bradycardia risk, obviously it's hemodynamically pretty stable. Patients can be very, relaxed with it, but can still, follow some commands, which is what we want patients to be doing when they're having awake craniotomies, because we want to see what's happening up here? Is, can they
See, this is the thing that freaks me out the
Yeah.
most about human anesthesia is that your
Yeah.
patients start talking in the middle of stuff. Like I had to spend a day, like when I did my human anesthesia rotations, we did OBGYN and, we kept going to cesareans and, they were talking. And I was like, oh, I'm going to pass out, right? Because I was like, I'm not used to things being like awake and sentient and verbalizing and being like,
Right.
oh, I feel nauseous or, oh, I feel pressure. I was like, oh, like I was like, that freaked me out big time. So I was like, the verbal component of human anesthesia
Mhm.
is definitely weird from our point of view, I think. So,
Mhm. Yeah.
did you want to ask another question before I think we're probably close to wrapping up, aren't we? So
Let me
we
see.
should
Sort of,
end
yeah.
with Alex. She's got the glasses back on.
I love that. I love that.
So I think we actually can answer most of them in our discussions, but and you were talking about this before with regards to anesthesiologists in veterinary practice, but what is your threshold for when should an anesthesiologist be doing the anesthesia as opposed to the anesthesia that a pet might get, for example, in their local practice?
Just depends on how much you love your cat and dog.
This question is fire.
I'll give you my answer. So, unfortunately, it comes down to, for the longest time, it came down to money, right? So, like, the owners has the money to spend, they can have an in-person anesthesiologist at their vet clinic come in. Now, an in-person, the going rate in the US for an anesthesiologist is usually $250 an hour with a minimum of $2,000 a day for the practice. Okay. Very little owners can afford that. The top 1%, probably not even. Okay. And that's to a regular vet. Now, some referrals do have an anesthesiologist, very few, very, very, very few, rare. Now, I mean, there are some options to increase access to care, and and so we do that with our. I have a teleconsulting company that does that. So we have some anesthesiologists that do video call remotely with veterinarians to increase access to care and make it affordable and doable. But for the longest time, people did not have access to one of us. It was insanely expensive, which is sad, really sad.
I
Yeah,
think
and I think too. Actually, Bailey, go ahead. Go ahead. Go ahead.
I was gonna say, I think once you know what the world of veterinary medicine is like and the equipment that we're using and the people who are using that equipment, my threshold is really low. Like my own cat, who is healthy, does not have kidney disease, somehow at like 16 years old, or no, I guess this was probably 3 or 4 years ago. She had to get a dental. Um, and I was like, well, she has to go somewhere with an anesthesiologist because I know what's out there and I know how scary it can be if you know everything that the four of us know about anesthesia. And so I found a dentist who would let me run the case. I was going to take her to the university. That was my other option because I know the anesthesia team there and I know they would provide good care. But like, yeah, my threshold is really, really low. Like there is, and I work in America and I work in Illinois, who has like it's so state dependent here. Like in Illinois, you can't be a licensed CVT unless you've gone to school and passed the exam. In California, you could become like a CVT or RVT, or like there were two different licensure things you could get. But one was you went to school, passed the exam, and the other was you practiced for X number of years and passed the exam. So
And
like,
I think we need to specify. So CVT is certified veterinary technician. RVT is registered veterinary technician, which is sort of the equivalent of a registered nurse. It's just I think for some sort of trademark issues in the US, they can't use the term nurse for veterinary nurses, which I think is
You can't in
stupid.
Ontario either. You can't use veterinary nurse. The nurses union will come right after us. So we use veterinary technician, but
yeah.
which I
And the
think is
equipment's
silly.
all like, the equipment's so old. It's like shit that was like probably used in human anesthesia in the 60s. Like the safety features are so few and far between, and we're not,
Let's not
required
forget that
to.
some practices build their own circuits and machines too. So sometimes you'll go
Holy
to a
shit. No,
practice
yeah.
and you've been called in as a locum or they want to do some continuing education. And I can barely figure out the machine because it was like hand built by Dr. Ron in 1979 and it's never been upgraded. And you're like, I don't know what's going on here. But yeah, I agree with Bailey. My threshold's pretty low. And I actually think if you look at the literature, because every 10 to 15 years they produce these big multi-center international studies looking at anesthesia related mortality. And specifically, we look at it in horses and we do like the common small animals. So, in other words, dogs and cats. In our mortality, you would the overall mortality, especially compared to example between like an academic institution or a high level referral versus general practice, you would find, I think, the mortality levels, especially in the general practices, unacceptable.
Yeah, for sure.
Yeah. But the owners don't know. The problem is that the public, the general public, totally ignores all of this, right?
But
Like,
they don't know. They don't ignore it. They just don't. There's no way for them to know that information. Unfortunately, it's it's heartbreaking. It's heartbreaking.
there is no
The way-
And there
transparency.
are places too that I've actually seen, and like long before I was an anesthesiologist and I did my own GP, like I work for somebody, and the way it worked is that while the technician's assistant, who's non-certified, non-licensed, is basically just, trained off the street in the hospital, would both be cleaning the teeth, monitoring and recording the anesthesia all at the same time. So would I take my cat there? Absolutely not. My cat only goes to tertiary referral. And so like if I was, even if it was a spay or a neuter or something even more straightforward, I'm straight to tertiary referral. And I think that's what it is. It's one of those things like the more you know, the more terrified you
Yep.
become.
Oh
But
yeah.
unfortunately, like John Lucas said earlier, I mean, over 98% of the anesthesia that goes on in vet med in the world does not involve an anesthesiologist. And actually, at the end of the day, you will find that they mostly do live. But when you actually look at the papers and look at our mortality and our morbidity compared to human centers, you would be horrified.
Oh yeah.
Yeah, 100 times more. It's crazy. It's crazy. But like, bringing a pet to a tertiary referral involves paying probably 10 times more.
Yeah.
Right, the same dental clinic that you can do in a practice for $800 to $900 US dollars in a tertiary referral is $3,000, right?
And
Like,
then you
so,
have that.
And also too, like I mean, my referral hospital is the northernmost referral hospital in the province of Ontario. Basically the next closest referral hospital north of me, you have to go over the other side of the world in Norway. So, I mean, people aren't going to drive 11 hours in Canada in the middle of winter to have their cat neutered because there's an anesthesiologist. It's just not going to happen. So we also have some pragmatic constraints too. It's just there aren't enough referral centers. They're non-affordable. And unlike the
There's not
UK,
enough of us.
there's not enough of us. And unlike the UK, where over 85% of domestic pets are insured, right? Our capture is less than 20% in North America, which I never understand because I find pet insurance incredibly affordable. But at the same time, and like you all like guaranteed in the life of your pet, as you very well know, you will always run into an incident like either a trauma, like, I mean, dogs eat stupid things like corn cobs and underpants, or they run into sticks, or your cat has, cats love to go into renal failure because they're desert species. And anyway, and in your pet's lifetime, like you're going to hit a vet bill that will pay you back cent for cent for whatever you have invested in your pet insurance. And like that message just doesn't percolate in North America for whatever reason. Whereas in the UK and the EU, it's incredibly widespread. So people like very straightforward, ordinary people will walk in, they won't even bat an eyelash at a $40,000 estimate for their dog because the insurance captures, 95% or more. Like their copay is $500.
Yeah.
Here though, like people will second mortgage their house, right? Or they'll just put it to sleep. So it's a very different culture. And unfortunately, it's detrimental to the animals, which is why we get very frustrated.
Yeah, you see a lot of GoFundMe's as well for
Yeah.
Yeah.
And a lot of stuff in the media about how we're just money grubbing pieces of shit. because all we want to do is, veterinary care should just be free, and there's apparently no overhead, and our training doesn't mean anything. So it's not always the happiest profession.
No, yeah.
Yeah.
I understand it's a very stressful profession.
It is. It
Yeah.
is.
Yeah.
Well, on that very sad note,
Not how I was hoping to end that podcast.
well, I guess we'll have to have you another time as well, because I think we have a long list of questions and we haven't gone through.
We didn't even get to ventilation.
Or
We
the
didn't
hot
get to
dogs.
any of it. Like
Count your blessings, Dr. Hamilton. Bailey didn't get to you about cat sympathetic tone and ventilation.
Oh my god!
Oh my god! Is this the first podcast we haven't talked about hot dogs?
Holy cow!
I mean,
We forgot the hot dogs.
We didn't even talk about hot dogs. Oh my
I
god!
was
This is
worried
wild.
about the hot dogs.
Okay. So
Bailey is going to kill himself with coronary artery disease based on the number of hot dogs he ingests. See, so
I have a hot dog shirt on today. I'm ready.
Ryan is a hot dog connoisseur.
Mhm.
So he
Legit.
goes around and tests
Yeah.
all sorts of different hot dogs.
And various sausages or meats that might be like a sausage.
any tubular meat, really.
Yeah.
That's
I'm pretty loose with my definition.
Yeah, as we tell this to Dr. Hamilton, who's a vegetarian.
So what is do you like vegetarian hot dogs? Do you have a go-to brand, or is there like a hot dog like a vegetarian hot dog you had one time and you're like, wow, they really knocked it out of the park?
So no. But so what I would I would say is that I'm mostly vegetarian. We don't buy meat, we don't cook it. But if I was to go to someone's house and that's what they'd made for me, then I'll eat it. So I'm one of those. You can't
You're
really
a moral relativist. No, that's totally cool. So are we.
So, but that's prefacing my answer about hot dogs. So when I did eat more meat, we went to Iceland, and there's a very famous hot dog stand in Iceland.
Holy shit!
Dr. Hamilton, this was on our last podcast. This exact famous Iceland hot dog thing. Our second podcast where this has come up.
There's a very unflattering photo of me with the hot dog in my mouth, which we have on, we have one of those little screens that rotates photos digitally. And so every now and again, this photo pops up of me looking awful, eating this world famous hot dog.
I should have bought my flight to Europe on Iceland Air so I could stop in, get a hot dog, and then
stop over. Because behavior is
do the stopover, have the hot dog, go to the Blue Lagoon, and then get your flight the next day.
Yeah. Mika, because you're Scottish, so I'm just going to test the waters here a little bit. So let's say you were having a night out in Scotland. Specifically. Are you going for a late night kebab or buddy or so you're going to eat meat when you've been on the town in Glasgow or what have you?
So I would probably not get a kebab. I would probably go for chips. And when I say chips, I don't mean the crunchy ones. I mean
we know,
proper fries. So chips and cheese was a favorite. And actually, when I was at university in Dundee, there was a 24-hour bakery, it was called, which is where everybody would go after a night out. It was a bakery, but it also made chips and cheese and curry sauce and baked beans and
did it do
hamburgers.
Because I know also Scottish people will deep fry anything. It's not just the Mars bars. It's deep fried slices of pizza. They'll deep fry the entire cheeseburger.
They'll deep fry a whole sausage.
Yes.
Yeah. Sausage supper.
Yeah. I had that. It was so good.
It took me until I was in my 20s before I realized that the pizza from the fish and chip shops was deep fried. I honestly thought that was just what pizza was.
Holy cow.
And I didn't realize until I was in my 20s that it was deep fried this whole time.
The Italian is clenching every sphincter in his body. Now, this is another famous podcast topic of ours, is how other people ruin pizza. And he specifically focuses on Americans, but now I think he's switched his allegiance of hatred to the Scottish.
I'm sorry. It does taste very good though. So
No, that's okay. That's okay. I'm not. I'm not gonna go into pizza. But yeah, definitely we need to have you again for another episode because we have so many more questions and an hour just flew
I
by.
know.
Thank you so much for being here with us. Thank you, everyone. I think the next episode is going to be Ryan again, right?
We're going back to ventilation, part 2.
OMG. OMG. All right. Thanks, everybody.
Thanks, guys.